Okay. When we're talking the left main, please remember this picture. This is a picture by the Dr. Birmani, which is a very famous person. I'm sorry. Okay. This doesn't work? Okay. So the right-hand side is by the pathologist. So by Dr. Birmani, you see like it's very diffuse disease. Starting the LAD to the left main, circumflex to the left main, this is all plaque. That's always, right? And we did the study using the IBUS. And this IBUS study, we did the pullback from LAD to the left main and circumflex to the left main. So we see both side branch directly. And we see 90% of the time, the plaque continue to the LAD to the left main. The next, when we're talking the left main, what is important is it really left main disease? That's the most important question. Many times angio lie. Next, if you see that has to be treated, what is the diffuse distribution of the disease? In this meaning, I meant what is the distribution of the plaque as well. And then, what is the most important, how big the circumflex vessel size, because that's determining whether you can put stent into the circ, or you should put the stent or circ, those things. So let me start with this case. So this is 60-year-old female, and the patient is going to be liver transplant, and this is an angio before transplantation. So what do you think? I think the left side picture is very famous angulation, meaning many times when we take that picture, looks left main osteum is bad. But we thought this picture is also looks very stenotic, and we just worry. But before looking IBUS, we have to remember that distal left main is actually ectatic or huge. So because we are comparing the large distal left main, we feel the osteum left main is very significant. This is IBUS from the LAD. It's a big artery. That's a dia. And still this is a LAD, super big. And that's why the circumflex coming to the left main. And this is a distal left main, is huge. And still we are in the left main. And you see the very funny shape of the osteum and connected to the outer. One more time. Number one, this IBUS picture is not great because almost we are field of view, so we have to change the zoom before starting, number one. Number two, we come back to the osteum because our interest is the osteum, so we have to disengage the guy to see the outer, right? So this is a summary, and you see this IBUS was not great, but we confirmed the connecting the outer, and then when we analyze the minimum lumen area at the osteum is 9. Which is great. And why we see such stenotic is because we are looking this way. When we look into this way, we are comparing this diameter versus that diameter. It's almost 50%. But many times, osteal left main is funny shape like this. Because of this, many times we confuse, looks like stenotic. So this is okay left main. Next. And next, this patient looks like stenotic. And I see the dumping of the guide as well. So you worry distal left main as well as osteal left main, right? But based on this picture, I do think that most people feel osteal left main is quite significant. That's the feeling, right? And this is IBUS. Actually, distal left main was quite significant, and the mid segment was okay. This is the osteum. And this osteal evaluation is very important. This is a measurement of the other segment, and distal left main was quite significant. And osteum, I can make the cartoon for you. This is a plaque. Wow, this is significant. This is a lumen. It's not significant because lumen is already connecting the aorta. This is not causing the small lumen. And why we feel this is dumping or looks like stenotic by angio is because guide was sitting like this. So when we pushing to the guide, actually you are almost making the stenosis by the guide. And they are geographically look stenotic, and sometimes we see the dumping. But this case is actually most important stenosis in the distal left main is not ostium. But I do agree, when we treat this type of the left main, I think putting the stent up to the ostium should be the good idea, because there is a chunk of the plaque as well. Next. You see that this case was relatively long compared to the other case, long left main I meant. But importantly, like diffuse disease, like left main caliber doesn't change too much compared to the proximal mid distal, and almost distal left main size is similar to the circumflex. Do you think that's left main stenotic, significant? We are not very clear, because if we say diameter stenosis, I think this is almost like 20-30%. Doesn't look bad, right? This is IBUS, and I'm surprised. Actually, mid left main was quite significant. You see the mid segment corresponding B is 4.8, which is very significant and very diffuse disease. And LED ostium C is also 4.9. So that's changing whole strategy. Or if you don't do the IBUS, you may say this left main is okay. That's a big mistake. So I think number one importance of the left main, correct diagnosis. Okay, so what is the number we should believe? The left-hand side is from South Korea by Dr. Park. He did 2 papers to compare the isolated left main lesion versus FFR. And then based on the FFR less than or equal to 0.8, what is the best cut value? They say 4.5. But remember, South Asia, including me, we are small compared to like the Caucasian. So I think 4.5 may not be accurate for the big people. But anyway, this is one important paper, number one. Number two, this is from Spain, and they analyze the left main based on the lumen area. And then if that is more than 6 square millimeter, leave it alone. If less than 6 millimeter, treat. And this study, it just confirmed deferring the based on the 6 square millimeter is safe. You see the medical treatment, if that is more than 6, they're okay. So I think those are probably the best data which we have. So if we analyze the left main larger than 6, it's probably safe to defer. In the middle, you have to discuss, meaning how much the plaque, it's more vulnerable plaque or calcified plaque, or patient is huge person or like small person. I don't think the small person 6 square millimeter, 6 square millimeter should not be same for the small person and the large person, right? And the other important point is this one. This is a correlation between the physiology versus minimum lumen area by IBUS. And what I meant is the bottom is the correlation in the non-left main lesion. So when we analyze the non-left main lesion to compare the MLA and physiology, you see a lot of lesion which apply to here. What this meaning? You get the small MLA, but FFR is negative. Because epicardial artery is a lot of variation, sometimes very small and sometimes small territory. So we cannot decide based on the MLA only. That's the epicardial artery. Overall, accuracy using the MLA to predict physiological positive in the non-pericardial artery is 70%. But the left main is actually different. You see the same place, meaning the MLA is small, but FFR is positive, is very small if we are talking the left main. The reason is because left main myocardial territory is very homogeneous for everybody, meaning left main cannot be small territory. Therefore, actually using the MLA to predict FFR positive or negative, left main is much more accurate compared to non-epicardial artery. Therefore, when we decide left main significance, we can use the MLA on top of the physiology as well. Next case. So this is the case the patient having the syncope, which happened very recently. So when we look into this angio, we thought, distal left main was haziness, and also the caliber is small, so we have to take care of this, what's happening. But angio cannot tell us too much. And this is I was pulled back from the LID, circumflex, and this is a left main. And then coming back, and this is a proximal portion. Okay, come back one more. And this is a LID, that's a circumflex. And here, I see the organized thrombus on the top. And then deep side, I see the plaque rupture, which are a little bit difficult. But altogether, this case, really, left main was stenotic, only 3.8. And also the LID was also a lot of lipidic plaque. And circumflex ostium was also stenotic. So altogether, we confirm this is very significant, but not only the significance in terms of the lumen, but also the plaque morphology. I see the thrombus on the top, and a little bit difficult, but deep side, I see the plaque cavity, so that's indicating probably recent plaque rupture, organized thrombus, that's causing this type of the stenosis and patient recent symptom. So that's very important left main. Okay, so we treat using the curate. And we confirm the Remus was very clean, so we just treat the LAD and circumflex. And when you see this picture, you see this is a correct size. You see the left main, distal left main, same size, and much bigger compared to the circ and the LAD. This is a correct picture. Remember how it looks like before. It's very small diffuse disease in the distal left main. So those kind of like common sense is very important. In this case, at the end, we analyze LAD ostium, left main is fine. And however, we couldn't bring in the IBUS into the circ because of the angulation. And in such, I don't recommend try to too much. And we just confirm from the LAD side. I think that's acceptable. When we talk, what is the cutoff value to predict the future event? Long time ago, the Dr. Park from South Korea, they show 5, 6, 7, 8. That's very easy to remember. But I stopped analyzing the POC because POC is very difficult. I think the interobservability is very high. Based on the angulation, we have very different numbers. So I stopped measuring the POC anymore. I don't recommend to try to measure the POC, number one. Number two, based on the Excel trial, using the all patients from the world, we see the cutoff value is quite different. And the left main is 10, and almost like 1 square millimeter larger compared to the South Korean people. I think the most important is because we are just looking at the different population. That's number one. Number two, this study is the outcome is only the angiographic diameter stenosis, more than 50%. So I think as of now, there is other multiple data, but I think left main size around 10 square millimeter, that's we should achieve. And this is the Excel data. If you have the better stent area, we have the better outcome compared to without. But what is important, this Kaplan-Meier curve is a difference starting the very early. What this meaning is very acute, like the stent failure, like stent thrombosis. Those things we can eliminate by doing the imaging because we can avoid mechanical issue. Okay, so what type of the left main plaque causing under expansion? And when we look into the pre-intervention IBUS, there is a two different type, which is very important to remember. Number one, distal left main, that's most frequent concentric plaque because distal left main is too big side branch and upstream. So flow divider, the plaque is out layer. So many times we see the concentric plaque compared to any other place. On top, if you have the calcified plaque, that's the most important predictor of the expansion. Number two, this is actually quite interesting. Sometimes the osteo left main having the very negative remodeling. Probably some of them could be related to guide spasm, but even we do everything, we see the small artery in the osteo left main. So like the vessel area is 4.2. And this case, when you expand, we reaching the 8.6. So whenever you see the osteoleftomen, sometimes you see this type of very negative remodeling. But if there is no calcium, you should be able to expand. When we are talking the calcium, this is important to check the calcium fracture. This is a before and after. You see the nice calcium fracture in the 6 o'clock and 12 o'clock, right? So please remember this picture. And then I'm going to show two interesting left main case, how we treat. So this is a left main. Actually, we thought the main region was proximal LAD. You see the proximal LAD, something funny slit, and osteo LAD too. And circumflex looks okay. And left main, we don't feel this is super significant. Those are the findings. But it looks like very calcified. And then we did the IBAS. This is an IBAS from the LAD to the left main. So number one, when we measure the distal left main is 5.6. So for us, we should treat. Number two, the very significant LAD region was really significant. That's the next second. So that's very significant and very, very calcified. In this case, I saw that the calcium is very longitudinally long, so we need some modification. That's our diagnosis in the LAD. And the supplies is actually circumflex. And left main, we confirm also significant. And by the way, when we look into the left main lumen, you should do confirm both sides. And smaller one is a correct number. Because many times IBAS catheter is not coaxial compared to the lumen area. And then many times we lumen looks larger compared to the real. So if you have the two different numbers from the LAD to the left main, circumflex to the left main, you have to believe the smaller one. So we confirm the left main is significant. But most supplies of the circumflex compared to the angio, we see the very stenotic region in the proximal circ. Originally, we planned the provisional, but based on this picture, oh my goodness, we have to do two-stent technique. That's our thought. Okay. So what we have done, so because of that circumflex region, we did the shock wave for the circumflex first. And then this is the IBAS after the shock wave. I put the top, that's before shock wave. I put the bottom, this is after the shock wave. And you see the nice calcium fracture in the both sides at the side of the smallest area, right? So because of this, we thought we call this is controlled dissection or controlled fracture. Meaning we didn't make the big flow limiting dissection, but we make it larger. But this dissection is not flow limiting, so we thought this is actually good for the provisional. The other things which we thought is this phenomena. This is a different case. This is a before and this is a after crossover stenting from the LAD to left main. And you can see the osteocyte angiographically. Before is okay. Post is very stenotic. And what this meaning is this is a circumflex IBAS before crossover stenting in the LAD to the left main is big. Post looks like they're squeezed. But lumen is actually almost preserved because just shape is funny. This is we call the carina shift. And when the carina shift often occur is the time when the circumflex is little disease. Like when you don't have the disease, you are more likely causing the carina shift. And then we thought our case is actually opposite, meaning we have the chunk of the calcium already like the natural stent, and we make the good fracture. So lumen is okay, and we didn't make the flow limiting stent fracture or dissection. So I think, and we don't expect the carina shift because it's a lot of calcium, almost like rigid. So then, based on the findings, we saw that this case is very good, just provisional. And then we put the stent into the, we did the IV shockwave in the LAD first, and then putting the stent and the port and post dilatation, everything. This is after all procedure on the LAD. So this is a before and this is after. At the site of the supercalcified region, now you see the good stent expansion because we make the fracture and balloon, so it looks like very good. You see the left main is 11.2, we are happy. LAD is 8.6, we are happy. That's all. And this is a picture. And LAD looks good, but that picture make us happy because circumflex looks very good. And actually, we didn't do the IBUS into the circ intentionally because we didn't open the circ. We just leave it alone. We didn't kiss. Because if we start chasing the circumflex, we make it worse and we need to stent. But pre IBUS, as well as the post-shockwave IBUS, tells us we create the control dissection, and that was very calcified. And I don't think that's causing the collineal shift. And altogether, based on the IBUS findings, we intentionally do this way, and we didn't do IBUS at the end. That's one case. Next one is kind of different, but showing the different aspect. So this patient is young, and you see the left main, and we are not very sure if this is really distal left main is significant. But that view looks like some stenosis, so we have to check whether this is significant or not, right? And this is IBUS? Yes, the left main was surprisingly very small and a lot of soft plaque. But the LED looks okay, and some disease which is more distal. And then even, by the way, the other important point of this case, whenever you see this type picture, you are not sure this is trifurcation or this is separate diag. We are not very clear by angio, but we really confirm. Actually, the diag is much far from the ostium, so this is not trifurcation. We are just treating the bifurcation. That's number one. Number two, there is a second region distal to the diag, and then we measure all diameter, and then based on the distal segment, 4.1, okay, we can put 3.5 stent, and not much taper. That's what we decide. And the left main is 4.3. Interestingly, left main was not too big, but that's our measurement. Based on this, we decide, let's put a stent distal to the diag, crossover to the left main. That's our decision. But this case, what is more important is circumflex. We did the circumflex IBUS, and this IBUS is actually, to me, is very interesting. You see the very proximal is quite normal, 5.9. I'm so happy. But after branch, the vessel diameter is 2.9. And after the second branch, vessel diameter is 2.4. So number one, it's normal or not much disease, so it's okay to the provisional. But vessel taper significantly because a bunch of the branch in the proximal portion. So if we need to stent in this circumflex, we have to put a very small stent, which is not very good. That's our concern based on this circumflex IBUS. Additionally, we check the left main, that's confirming the significant, right? Okay, so we did the stent. First, we balloon into the LED, and we balloon in the left main, and finally we put 3,538 stent in the LED to the left main. We did the port, and we did the additional post-dilatation. This is at the end. Are you happy in the circumflex? We are not. Looks like something hedgy in the proximal portion. We are not. In this case, we decide to the IBUS into the circ. Even though we didn't open after good port, we don't have to open. We just go ahead to the IBUS grows easily. So this is, this is IBUS from the LED to the left main. Nice. Left main is 8.6, fine. LED 8.1, fine. So we are happy for the LED. And we open the circ, and this is IBUS from the circ without ballooning. So you see, nothing significant, meaning no dissection, but roommates look smaller. But this IBUS is quite confusing, so I just putting the side by side. This is a before, and this is after. So this portion is same, there is no dissection, but something funny because of the, looks like small. And next picture, outside here is something funny, but compare here, this is definitely side branch. And here, no change in terms of the plaque, but looks like vessel is small. So altogether, we think this is all spasm. So I don't think this is disease. How to differentiate spasm and real disease? You have to see the thickness of the media. So this media is thicker, this black is thicker, so that's number one. Number two is plaque doesn't change too much. When you have the spasm, thickness of the intima doesn't change. So to me, this is, everything is spasm, so we thought it's okay. So what we have done, we just give the nitro, and this is a this is Yeah, sorry. So we just give the nitro. Can you go back one if you can? So we just give the nitro and we see much better angio. So it looks okay. But why we leave it alone is because of the IBUS appearance. Meaning we diagnose this is ospasm and then no dissection. So we really don't need to touch the circumflex. That's our decision and we finish. Okay, almost done. So the last thing what is important for the left domain treatment is this phenomenon. So this case was protected left domain and stent was implanted to suck to the left domain. And after the treatment, we see this pattern. This is only one stent. You see the multiple layer, and this layer is different compared to the overlap. Like this is very disorganized strut. This is so-called stent deformation, which we see many times in the osteal left domain. And this happened about 6.5% in the Excel trial. And if happened, they have poor outcome even adjusting the minimum stent area. Okay, so this is end. Finally, why IBUS is important for the left domain is this data. This is the data from the UK. They compare with without imaging for the left domain treatment. This is registry. This is not randomized, a lot of bias. But after adjusting everything, doing the imaging for the left domain treatment, they show the adjusted data, we can reduce the all-cause death. So you can see the mortality at 30 days, its odds ratio is 0.54. That's meaning we are reducing the all-cause death 46%. And importantly, compared to prior couple of Mahera, you see the main difference occur very early stage. So we are reducing the mortality by avoiding the mechanical issue. Additionally, this is the data from the Renovate PCI. So they show, based on the complex PCI with without IBUS, reducing the event. And importantly, in this data, this is the first time showing the cardiac death was reduced based on the intravascular imaging. So you see the hazard ratio is 0.47, is almost half. We decrease the mortality. And additionally, this is subgroup analysis. You see the left domain is higher, lowest hazard ratio to making the better. Finish. Okay, I think I talk a lot, so I don't think I have to repeat. So that's all. Thank you so much.